Hey there, welcome back to Speaking of the Village. So glad you're here with us today. I am your host, Dawn Thompson, with my co-host, Nicole Harlow. And we have a guest with us today, Sarah Thompson. And we're going to dive into a really amazing topic of preeclampsia and nutrition and how it can actually impact your birth and postpartum experience. And I'm especially excited to talk about preeclampsia, Sarah, because I've been doing this work for 23 years or something like that now. And I've seen a massive, massive jump in women being diagnosed with preeclampsia. So I think there's so much to talk about this. And even if you're pregnant right now and you just think, oh, well, I don't need to listen to this episode if it's about preeclampsia, but with a large number, 200,000 right now is the number estimated on how many people are experiencing preeclampsia. I would say that's probably even more, in my opinion. You know, statistics are at least 2 years behind, but my guess is that's continuing on that upward trend. It's more than doubled in the last 20 years. So that number is more than doubled. So with that, Sarah, welcome. Thank you for being on the show. Please, share with our listeners a little bit about yourself and what you do.
Absolutely. Well, thank you both, Dawn and Nicole, for having me on today. And preeclampsia, I mean, this is one of my, I hate to say favorite topics to talk about, but it's one of those conditions that I feel like women are given very little resource on how to prevent it, how to treat it, what they can do. And there is a lot of information out there that is available, and we'll go over some of that. But for those who don't know who I am, my name is Sarah Thompson, and I am a functional medicine provider who specializes in perinatal care. I have two published books, Functional Maternity, using functional medicine and nutrition to improve pregnancy and childbirth outcomes, and a second book I published this year, Beyond Results, which is more of a lab analysis textbook. I see patients at my clinic in Fort Collins, Colorado, and I also teach midwifery continuing education courses. And I have been doing this for just about 20 years this year,
Yes.
which is always exciting, right?
Yes.
Big
Well, and I
milestone.
should say there is no relation, even though we have the same
Yes.
last name. But funny, my daughter is in Fort Collins as well.
Oh, she is. Awesome.
Yeah.
Small
Yeah.
world.
I know it is. Great place. I love it there.
Yeah, we do too.
Yeah. I don't get to visit as often as I would like to, but I'm hoping to change that soon. But she just bought her first house there and is just in love with the area and has no intentions of coming back to San Diego.
Fair.
I'm gonna
I know.
go.
It
I'm gonna go
sucks you
there
in. It
instead.
sucks you in. I came out for college and never left myself. So
Yep.
it's a good
That's
place.
great. I mentioned about the extreme increase in preeclampsia, but let's probably get down to the more linear or more granular and talk about what preeclampsia is. Let's start there.
Yeah, so preeclampsia is like a blanket term for almost like a toxemia-based condition in pregnancy. And the easiest way to explain it in kind of like a broad term is almost like the body becoming pregnancy septic in a way,
Mm.
right? It becomes this progressive condition in which the body begins to react from like a toxic level to the placenta. So it can generate from either side, really, the maternal side or the placental side, and it becomes basically the mother becoming sick and very significantly sick during her pregnancy. So that's kind of like a basic try to, break it down to more mild terms. Really, from a medical perspective, it's an organ shutdown if we let it go too far. Right? The body literally will shut down. And that's why we see things like eclampsia and the eclamptic seizures and that side if we go all the way to the other end. With conventional medicine, our goal is to catch it early so we don't get to that eclamptic phase. And in the conventional model of care, the treatment for preeclampsia is delivery. But there's so much more that we can do besides just waiting till it gets bad enough for us to say, well, it's gotten bad enough. We should just take our baby, right? We should just end this pregnancy.
Yeah.
But there's so much out there. There's so many underlying causes. There's so many things that we can do preventatively, both preconception and in the acute crisis management phase of preeclampsia. And it's understanding the different mechanisms of action. And I know that within the conventional model, they'll say we don't know what causes preeclampsia. And I sometimes find that the reason we don't know what causes preeclampsia is because we're looking for one cause.
Mm-hmm.
But the reality is there's more than one cause, and there's usually layers of causes that are almost like a domino effect that gets to that point, which is why every case of preeclampsia really presents quite differently. even within a mother who's had preeclampsia in multiple pregnancies, each individual case of preeclampsia patterns very differently. And it's looking at each individual pattern and the uniqueness of that mother that we have to do in order to figure out why that preeclampsia pattern occurred in that specific pregnancy.
And Sarah, I know you just said, obviously every mother's going to experience it different, every pregnancy is different, but just for those who, maybe first-time moms, maybe have just heard the term but don't
Yeah.
really know what that even could present as, what are some like more common symptoms
Right.
that, may be a red flag for, I mean,
Yes.
obviously their providers are likely going to be testing for them, but for themselves, I know my sister had it with both of her children and they, again, presented very differently in both.
Absolutely. I mean, the two classic features that we see with the diagnostics for preeclampsia are hypertension, so high blood pressure, and proteinuria, or protein in the urine. And those are two overt signs of tissue damage and inflammation or physical stress in the body, right? And it's just, again, figuring out which one is at play there. When we have proteinuria, that's kidney involvement. And obviously, if we have, a hypertensive component, that's a cardiovascular component, but the liver can also be affected. We can see other systems being affected. Most people who develop a preeclampsia, where we do have the high blood pressure and the protein in the urine, 9 times out of 10, when I look at their history, they had symptoms before those things happened, but they got, I don't want to say misdiagnosed, but they got told that that happens in pregnancy. Oh, that's common in pregnancy. And then all of a sudden it's not common in pregnancy. And all of a sudden it's not normal in pregnancy. Some of the big things we'll see is, puffiness, swelling, right?
Yep.
Anytime I have a patient who's telling me they're getting swelling, I'm always asking for details on that swelling.
Yeah.
There's an element of puffiness that's normal in pregnancy as we get things like hemodilution and those capillaries and everything expand. And then there's a type of edema where we're getting, what I call the squishy factor, right? We're losing fluid into the tissues, and that is a completely different game. And that is a sign of either kidney involvement or cardiovascular involvement,
Mhm.
regardless of what the blood pressure is doing, right?
Right.
And then we have
I could
cases at
see it
which, yeah.
as a doula. I would see, I mean, I could see preeclampsia in their face.
Mhm.
Like I would see it. I saw actually she was a esthetician that I used to go to, and I just saw her out and about at a restaurant, and she was right at the end of pregnancy and all of that. And I saw her face and I was like, and like, I didn't want to say anything, but I did. I was just like, how's your blood pressure? And like, I'm like, I think you need to go check in with your care provider. And
Yeah.
sure enough, you know,
Yeah.
she had developed preeclampsia, and she said, I'm like, are you having any headaches? She goes, oh yeah, I've been having a headache for like the last on and off for the
Yeah.
last 2 or 3 days. And I'm like, yeah, that's not,
Yeah.
that's not normal. But yeah, I mean, I could just see it in her face. Like her lips looked like she had lip injections, and just right here was super puffy. And I was just like, ooh,
Yeah. Well, and
something
that
going
goes
on.
into some of those other symptoms that oftentimes get ignored. I hate to say like ignored, but we just kind of say, oh, that happens in pregnancy, right? Because sometimes it does happen in pregnancy. But as providers, our job should be, is that a normal pregnancy? Oh, we've got some hemodilution. Oh, we've got some, it's just blood flow issues. Like, that can happen as we get hemodilution and stuff. Or do we really need to take a look at this? And our job should be to rule out the possibility of something bad, to say, okay, now we can consider that idiopathic to pregnancy. But
Right.
headaches are one of those, right? Headaches can be an early onset feature of preeclampsia, regardless of
Mhm.
blood pressure,
Right.
right?
So let's talk about what you, in your work, that you have discovered that are possible reasons for preeclampsia.
So, I mean, the main feature that we'll see with preeclampsia is this idea of endothelial dysfunction, right? And I think endothelial dysfunction is like an IBS term. Look, these cells are sad, right? Oh, those endothelial cells are a little bit inflamed. They're not functioning correctly. And again, we have to go to that next layer of why. Most of the time, when we look at preeclampsia, we think of it as almost like a disease of either preconception or first trimester, when the placenta is developing its cardiovascular connections with the maternal uterus. And these things happen with what the egg and the sperm bring together to create the blast or the embryo, right? Now, in those first couple weeks of pregnancy, that's when we're developing that placenta. The placenta is growing from implantation till about 10 weeks. That's our first phase of placental development. And what we had outside of pregnancy coming in with that embryo, as well as mom's hormones during that first trimester, really influence what we call angiogenesis, which is the development of teeny tiny little blood vessels throughout the placenta. If our blood vessels in this early phase don't develop correctly, then we can, as the pressure and the demand for baby accumulate later on, then we start to see dysfunction from that placenta. And the blood vessels for the placenta are doing so much more than just pulling blood in and out of baby. This is the blood life force for the cells of the placenta itself. And one of the primary things will be that we see associated with quote unquote endothelial dysfunction is this idea of hypoxia. Hypoxia just means low oxygen at a cellular level. If we don't have oxygen at a cellular level, we can't make energy, right? Things don't function very well. I mean, we could dive into cell biology all day long because I think it's fascinating. But that's where this is happening, right? This is happening in a cell. And we're talking like, microscopic areas, and this is going to affect the whole maternal physiology. But hypoxia just means that low oxygen. We can, again, see so many things associated with that, whether it's poor blood flow, anemia, and oxidative stress and inflammation. So these two things, endothelial cell dysfunction and hypoxia, really drive the base of preeclampsia from that cellular level. So then, of course, we have to go into, okay, what are all the possible things that can affect that? Well, certain things in the first trimester, such as thyroid hormones and hormones like progesterone, very much affect that early angiogenesis connection. In fact, there's a really cool growth factor called vascular endothelial growth factor, VEGF, and it is highly associated with late onset and even early onset preeclampsia. And its primary role is to promote that angiogenesis, that growth of those blood vessels in that early pregnancy phase. To the point that we even have markers now, like placental insulin growth factor is one of these VEGF growth factors. And studies show that women who will become preeclamptic later in pregnancy have low levels of these specific growth factors in the first trimester. There is like a negative interaction with inflammation at that time frame. So if we have an element of inflammation, we get lower of these factors. Progesterone is associated with those factors. Thyroid is associated with those factors. There's lots of different things that can play into that early placental development, which then sets the foundation for the rest of pregnancy. And most of what we're talking about when we talk about that first trimester is actually preconception stuff. Right. When I'm working with patients, and something I'll tell the midwives that I work with is if you find a dysfunction at a specific phase in pregnancy, it didn't happen then. It happened months ago. We're just now seeing it. Preeclampsia is one of those. For the majority of people who develop a preeclampsia, it's what we call late onset preeclampsia. So it's later term preeclampsia. And when we find those people, we have to work backwards and say, okay, what happened in this other phase? And I kind of go back in 3-month increments, right? If somebody gets early onset preeclampsia, it was probably something that happened in that first trimester of preconception. But we have 2 phases of placental development. So we have first phase placental development, which is those first couple of weeks, so leading up to that 10 to 12 week mark. At that point, the placenta is like, yay, big, right? And then we have to take that placenta and turn it into a placenta that's yay, big. So that's a whole bunch of placental growth and placental health that still has to happen. And if something happens during that second phase of placental development, then we can still see that increased risk of preeclampsia later on in pregnancy. Following so far? I feel like I'm just like going for it.
I'm so interested. I love this.
Yeah, I mean, I think there's some of it that I'm like, can we simplify this for the average person to understand a little
Right.
bit? But it is fascinating. I mean,
Yeah.
like I'm of course in the more simple-minded, like, okay, what's changed in our
Yeah.
daily nutritional
And,
environment that it could be
right.
causing these, or environmental
Sure.
impacts? Because to have it jump double,
Yeah. There's a
just the
lot of
last
factors there, right? There's
something.
so many factors that play into the why are we seeing it increasing, right? And preeclampsia isn't a new thing. I mean, we have records of preeclampsia going back to ancient Greece. So
Yeah,
it has happened. Like it's not
yeah.
a new
My
thing. It's just
my
why.
husband
Yeah.
My husband's father's mother, so my husband's great grandmother, actually died from preeclampsia or eclampsia.
Hmm.
This was, whatever, back in way back.
Yeah.
And she had given birth to twins early. And probably because the preeclampsia had happened, she gave birth at home and then died of heart failure and seizure.
Yeah.
because they didn't know that that's what she had. So yeah, I mean, I know it's been there. It's just a lot more of it.
A lot worse, right? So that's where we say, well, what is making it more so, right? There's an element of genetics. We do see that, but genetics doesn't mean inevitable. That's why I always try to tell people, just because you have a genetic predisposition to something doesn't mean it's going to happen. It just means you need a little extra hug on that genetic, right? You may need a little bit more of something that somebody else didn't, and that's okay. We can work around that. But the why, right? Why are we seeing more of this? Again, one of the biggest drivers of all aspects of preeclampsia is this idea of oxidative stress. Cellular pollution is what that is. And oxidative stress can come about due to a number of different things. But the idea is that that individual little cell down there in the placenta is building up pollution. Now, every day, you and I are taking calories and turning them into energy. And just like our vehicle, if you're like me, you're still driving a gas guzzler, right? And I put gas in my car and pollution comes out the back so that I can drive my car to work every day. Our engines do the same thing. Our cellular engines, the mitochondria, powerhouse of the cell, does the same thing and it produces pollution. Now, that pollution, if it builds up in that cell, is just like sitting in your garage with the car running and the door closed. That's not good. Eventually, we're going to get sick. So the idea of preeclampsia is almost this idea of oxidative stress. And if you look at research, that is a very common thread. Again, all of the research, regardless of the underlying other mechanisms behind preeclampsia, is that all cases of preeclampsia have elements of oxidative stress. And so when we look at oxidative stress, it's either a buildup of pollution, right? And our body has these really great mechanisms that help us clean up this pollution on a regular basis, right? When you and I go to sleep at night, melatonin shuts our cells down so we can go in and clean them up. You wouldn't want to change your oil in your car if your car was running, right? That's dangerous. You don't want to grab this pollution out of that cell if that cell is still up and running. So we have to shut it down so our natural antioxidants can come in, grab that pollution, and take it to the liver for processing and detoxification. So this whole idea of oxidative stress and antioxidant balance and this back and forth becomes that underlying mechanism between preeclampsia. It's just how do we get that oxidative stress? What's happening there? And so when we see oxidative stress, there's a handful of things that we see increasing that risk of oxidative stress, right? Our lifestyle habits become a big one here. There are certain things like sleep apnea, people who go to bed late, right? Late at night, don't get good sleep habits. Guess what? They have higher rates of preeclampsia. Right? Sleep deprivation. There's a couple of really good studies on that. The other thing we see with oxidative stress is kind of this age-related game. Right? Moms, we're starting to have kids later in life. And as much as we don't want to admit it, because I guarantee I'm on the downhill here myself, I don't feel like I'm aging, right? But I'm definitely aging. And after a certain age, we see the rate of preeclampsia increasing because our cells are not as strong at reducing oxidative stress. That's why we age, right? And it's this chicken or egg game. As we age, we make less antioxidants. Do we make less antioxidants because our cells are aging? Or are we aging because we don't have as many antioxidants? Our primary antioxidants that we think about when we're thinking about oxidative stress are things like glutathione, superoxide dismutase, right? These are a couple of these antioxidants that our body uses in different ways to bind that oxidative stress, that pollution, and pull it to the liver for detoxing.
So I'm going to take a little bit of a left here because what this also is all like leading to for me, because this has been sort of a theory of mine about autism.
Well, and the autism game, that is another complex beast where we have to look at so many factors, just like we're looking at the preeclampsia side, is we have the genetic predisposition, and then we have all these other diet and lifestyle factors that also increase that propensity, right? The other things we think of when we're thinking about that environment lifestyle is what kind of toxins are we putting in our body?
Right.
Okay.
That's exactly what I mean. Like
Yeah.
when we're having this, I don't want to talk about autism, but I'm just saying it right now because, they keep saying like, well, we don't know the cause, or like, vaccines aren't the thing, and, that they're not the thing causing autism. And I've always had this theory that actually autism, if you have a predisposition, if you're genetically have a predisposition, that is frequently happening in the womb. That's what I believe. And long said that I think it's because our society has become toxic and our bodies don't have the mechanism to get rid of the toxins, or some people don't. different maybe because like, right when they research kids on the spectrum, and they test their nails and hair, there's no mercury in them. But then when they test their blood, they have high levels of heavy metal poisoning, right? Heavy metal poisoning. And I also think that that's why why some children's autism is triggered when they get a vaccine, because we're overloading their body with more heavy metals, where I think they got a bunch of heavy metals already in utero. And then, right. So like everything you're speaking to about preeclampsia, it feels like it could potentially be the same cause, and that really it's the toxins, it's the toxic environment, which then makes me want to have a discussion about like, okay, what are we doing before pregnancy to do what we can to offload as much of the toxins in our body already before we even have that baby?
Yes. And those are important things to consider. Absolutely. And this is where we have, I always say we have the controllables and the non-controllables, right? And our job is to control what we can, but also to let go of what we can't control. Because there's going to be an element of things that go into autism and preeclampsia and all these things that are out of our control, right? There's only so much we can do. And we as providers should be I think that there's an element of informed consent and education, and I'm a huge educator of my patients. But at the same time, what are we going to do with that information, right? Is knowing going to help us? Can we do anything about it beforehand? Or does that add more stress to that person to know that, right? So when I'm working with somebody, like I had a whole bunch of phone calls this morning going through cases, my job, again, with each individual case is taking into account all of these parameters and saying, for this individual person, what can I control and what can I not control, right? And it's going to be different from case to case to case, just like
And I
the autism, right? Each case is very different. It's going to be, what supplements this person was taking, what was this person exposed to in utero, what happened afterwards, what was their microbiome and their birth experience, right? Was it a cesarean, or did they have antibiotics because mom was GBS positive? Well, that just wrecked their gut. And we know that kids with autism also have really messed up guts, right? A lot of them
I
have
love what you
Clostridium.
said though, Sarah, because we talk about this all the time on other episodes when we're talking about like, the traditional allopathic medical providers, that it's more systemic and there's no individual care. And you literally just said for every single case, it's individualized and it's so different, right? Like I just want to point that out and like celebrate that awareness that you have of that, because I think, we talk about it all the time. We just did it on our last recording, like every single pregnancy, not just every single, person who is pregnant, but every single pregnancy is so individualized and it doesn't fit in any type of box, right? And this is a whole different layer of that. We were talking about more like care models and home versus hospital and induction and cesarean, but like what you're saying too, with adding in the potential for these onsets. So I just wanted to, like, if you're listening to this and you're a avid listener of Speaking of the Village, you've definitely heard me say this before, us say this before, but I want to call that out because it's the difference. I think it's the difference between having a provider that is there for you and having a provider that's just going through the ropes and like you're just the circumstance of whatever happens rather than the driver of it. So I appreciate that you take that approach.
Thank you. And it is
So,
something that I try to preach a little bit every time I'm on a show, only because I feel like there are, even within the functional medicine world, there are a ton of functional medicine providers who have lost focus of that, and they treat functional medicine just like conventional medicine, just with supplements, right? This symptom equals this supplement, and I'll get patients who are on 40 plus different supplements for a different symptom. And I go, wait, time out. That's not finding root cause, right? That's not critical thinking medicine. That's just taking the same model of conventional medicine and applying it to functional medicine, right? And this is why when I teach courses, everybody will ask me, well, what's your protocol for this? What's your protocol for that? And I don't do protocols. I have a bucket of possibilities that I'm going to pull from based off of this individual. And sometimes when I'm looking at what supplements and diet they may need, my job is to make sure that they're taking the least amount of supplements that they need to reach the goal. And supplements, the term supplement is just that. It's to supplement their diet and lifestyle. It's not to replace the diet and lifestyle. You're not going to supplement your way out of negative diet and lifestyle habits. And so as providers really should be focusing on those controllable factors, right? What can we control? Well, we control what we put in our mouth. We can control what we do with our body. And so that's where treatment focus should start.
So what can people do though? What can they do in the beginning of or before pregnancy? What can they do in that beginning stage of pregnancy?
Yeah.
Even if somebody's listening, they're 6 months pregnant right now, is there something they can do?
Yeah. So it depends. Again, it depends, right? I can't give you a blanket protocol for what they can and cannot do, but it's generally eating a good healthy diet, getting good moderate exercise, removing as many toxins as we can, making sure that the supplements they're taking are the right ones for them. And I mean, if we want to look at, like, I don't know, the most blanketed of diets that we can do based off of research for preeclampsia prevention, we lean towards the Mediterranean diet. Like, that's a blanket diet that has so much research backing for its ability to reduce the risk of preeclampsia that if we have somebody who has had a preeclampsia case or is concerned, first time pregnancy, that kind of stuff, that's something that without knowing anything about them, we can say, try to follow a Mediterranean diet.
And for those who may not know what Mediterranean diet is, can you just give a couple examples?
Sure. So the Mediterranean diet characteristically is a high antioxidant based diet is really what it ends up being. So it focuses heavily on like monounsaturated fats, which there's a lot of really cool research that talks about the use of monounsaturated fats for the actual acute treatment of
Meaning like olive
preeclampsia.
oil, right?
Yeah.
Olive
Olive
oil.
oils, coconut oils, avocado oil, but keeping, if we look at fats, we have our polyunsaturated, we have saturated, and we have monounsaturated. Polyunsaturated are liquid, right? You leave them out on the counter, they're liquid for the most part. In your cells, they kind of do the same thing. Too many polyunsaturated and our cells are a little on the floppier side, right? They make up the cell membranes, the outer layer of our cells. If we have saturated fats, what are saturated fats? They're very stiff, right? They're very solid. If we have too many saturated fats, our cells get really stiff and solid, right? Monounsaturated, oh man, they're like the Goldilocks fat, right? They're not too soft, they're not too hard, they're just right. And we find in research, it's like this idea of you can have a deficiency pattern of preeclampsia and you can have an excess pattern of preeclampsia. And it's almost like how this cell membrane shifts and you can have a deficiency phase where maybe they're too floppy, they're not oxygenated because we have anemia, we have like low levels of things. And then on the flip side, we have our saturated fats, everything's too stiff, so the oxygen's just bouncing right off of the cell membranes. We have lots of buildup of heat and toxicity and that kind of stuff. So we have a different pattern of preeclampsia as well. Well, monounsaturated fats really help to bring it to balance, which is kind of cool. The other thing about the Mediterranean diet is it tends to be very high in fruits and vegetables, fresh fruits and vegetables, right? Which tend to be where we get the majority of our antioxidants in our diet. And we see studies that talk about flavonoids and polyphenols and fiber and, all of these antioxidants, vitamin C, vitamin E, alpha lipoic acid, CoQ10, all these different ones, selenium, come from our plant-based foods for the most part. Alpha lipoic acid, some of these other ones actually come from organ meat, but that is also something found in the Mediterranean diet too. But if we get a good group of these antioxidant-rich fruits and vegetables, this becomes our foundation of antioxidants if we're going back to oxidative stress, right? If we're making pollution on a regular basis, we got to bind it and we got to get it out of those cells and push it to the liver. That's what our dietary antioxidants do, is they help to support our innate antioxidants like glutathione and superoxide dismutase. And, a lot of these antioxidants need these different nutrients in order to function. Selenium, zinc, manganese, like all these great nutrients. Other things with the Mediterranean diet, it tends to be high seafood, right? So we're going to get lots of iodine, lots of selenium, lots of zinc, lots of omegas, all these great nutrients that help to reduce inflammation in the body, regulate blood clotting, those sorts of things. Yes, there is meat on a Mediterranean diet. I feel like every time I talk about Mediterranean diet, like, well, that means I can't have red meat. I'm like, no, by all means, eat some red meat. Lamb, goat, like those are all classic Mediterranean meats. Very, very iron dense, more so than beef. They also they're not afraid of organs, right? They will eat the whole kit and caboodle. We don't really do that here. So that's kind of the classic Mediterranean diet. Now, if we look at research, on, again, preeclampsia diet research, there's other diets that they'll find being associated with lower risk of preeclampsia. One of them is the New Nordic diet, and that is high seafood, high vegetable. And then there was another study once that actually looked at different diets, and the one diet that they saw in that specific study was, wouldn't you know it, a high seafood, high vegetable diet, right? So that tends to be a common thread regardless of what you label it. Right. And for me, labeling the Mediterranean diet is just easier because you can go and find resources. versus me saying, I want you to eat a lot of seafood and I want you to eat a lot of this. This gives you a nice base. And there's enough research to say, yeah, no, if you follow a Mediterranean diet, that reduces your risk of preeclampsia. And
Period.
there's great websites full of recipes. The Mediterranean dish.com is my go-to resource for clients because they've put together a fantastic database of different recipes.
Nice.
Awesome. We'll
What's it
link that
called?
in the show note.
What was it called? You said Mediterranean
Dish.
Dish.
Oh, okay, cool. That sounds amazing.
But that's the first
Well,
thing to do, right? The second thing to do is get some sleep.
I've always suspected that it was, related to diet in a much bigger way than we realize. And I've also thought toxins in the system, but I feel like we're eating more and more packaged foods, which has a tremendous amount of preservatives, a tremendous amount of sodium, and
Yeah.
like the level of sodium that we're all taking in on a regular basis is insane these days compared to what we would have been. And I could see how, the Mediterranean diet could eliminate some of that, right? Because I mean, like, we're also living in a Trader Joe's world where people are just going and getting the prepackaged food. And even there's stuff that's like already seasoned and already, it's got the vegetables and you just open the package and you cook it all, one pot, whatever. But like people don't realize that it's tons of freaking preservatives in that.
Yeah,
Yeah.
it's a convenience, instant gratification world that we live in,
Yeah.
And I mean, listen, this is totally off like pregnancy topic, but not really because I am still, postpartum with my last child and nursing and, kind of dealing with my own diet and lifestyle, shifts. And it's interesting that we're talking about this today. I literally had went and took a hormone test and like got it back and the results and like just thinking deeper and deeper in this. But, talking to my provider, talking about, I'm a mom of four and this is what I do because I only have like 30 seconds to myself. And then talking about control and not controlling and this and that, right? Like, I think, and this is a blanket statement, but I think when you're pregnant or planning to be pregnant, like you want better for yourself and your baby than you do maybe once that baby gets here and you're like in the thick of it, right? So it's a good time to like make yourself that priority because again, I can only speak for myself, but I know that like as much as I want to make myself the first priority and I do in certain things, you may be able to hear them back there.
I hear all the screaming in the background. Yeah.
There's four little ones that are, constantly tugging and pulling at me and work and husband and, all of the things, right? So I think this, which probably adds to the stress that, I think it's really good to kind of just point out, hey, this is a pathway, right? That Mediterranean diet is a pathway to making it a little bit easier to do these things.
Yeah.
And not have to reinvent the wheel. So thank you for that.
Yeah. Yeah. And again, when I work with patients too, we do this thing that I call redlining, which my goal is to make any sort of dietary transition, any sort of lifestyle transition as easy as it can be. Right? I work with patients like literally all over the world, and being able to help them create a healthy diet based off of what they have available is a very important thing. And I remember I had a patient once who was from India and she had come to the United States, and I always offer free 15-minute phone calls before I ever schedule anybody for an intake. And I was talking to her and she was like, I'm really apprehensive about trying functional medicine again because I was working with a provider and he gave me a diet plan and I looked at it and I just became overwhelmed because it was nothing I'd ever eaten before. Right. She eats a very classic Indian diet. Right. And in her mind, she was like, I have to throw out my entire pantry and they want me to eat smoothies every day. Like, I'm not going to do that. Right. You just took away my culture, my food culture. Right. And so what we do a lot in the clinic is, again, what I call redlining is I want you to keep a food journal for me. And my job is to help you make what you're already doing work better for you. Right? How do we put more stuff in versus taking stuff out? I'm not trying to reinvent the wheel. That's not what we're trying to do here. We're trying to help you maximize with your diet and taking into account your lifestyle, your culture. What do you do on a regular basis? How do we make that better for you?
It keeps going back to the same thing, which is individualized care.
Exactly.
And
right?
which is severely lacking in
Severely
every
lacking
element of
because it
medicine.
takes time. It takes
It
time,
does.
right? It
And
takes
they don't,
critical
and
thinking. It's
most
not
providers don't
easy,
have it.
right? They don't have the time to do it. And this is
And you
why,
can't find it on Google, right?
exactly,
Like you
right?
can't find it on Google. You
Yes.
can't find it in social media. I think that's what we're all seeking, right?
Hmm.
Like this generation is like, wait, I can just go find the answer right now, when it's not the case with things like
Yeah.
this.
Right.
Yeah.
Yeah.
It's very
You're going to
true. And
get like everything to the
I have a bunch
masses.
of I have friends who are OBs, right? Like I work with OBs on a regular basis. I have nothing but respect for what they do because
Yeah.
it's hard. It's hard to
It's,
do what they do with the amount of time that they have. And
yeah.
their hands are tied sometimes based off of who they work for, the hospital, insurance companies, what they were taught and what they weren't taught, right? They
So
need
many.
help just as much as the women need help.
Yeah, for
And
sure.
I think it's sometimes hard for certain doctors to admit that they don't know it and that they need help, or that having their patients also work with somebody, like what we do, is going to help them in the long run. They think we're trying to take over and we're not. We're just trying to
Right.
supplement, you know?
Yeah.
I always joke my job is to make their job easier, right? I want all my OB friends to have for
Yes.
their clients to have beautiful, awesome births so they don't have to work that hard either,
Yes.
right? It's a
Yes.
win-win for everybody.
I feel the exact same way. I mean, so many people think that I'm anti-obstetrician, but I'm really not. Like I feel like they have one of the toughest jobs out there. And do I think it could be done better? Absolutely. Do I think that we have the tools? Because like I said on our last podcast, doulas in particular see birth in every location, right?
Mhm.
With all the different doctors, with all the and like, could we help guide them? Because there's things that they just don't see.
Mhm.
Obstetricians never get an opportunity to see home birth or birth center birth, and they never get to see their patient after the aftermath of what's happened to them.
Yeah,
And I promise you, if they did, they would want to change things. But I also understand there's a lot of ego involved, right? You don't want to admit that you've been doing something wrong, or that you could have been doing something better or different. Like it's so complex. The whole thing is so complex.
absolutely.
But sometimes we try to make it like black and white, like it's just this or that, and it's just not. And I know, Sarah, we had talked about going into also like how nutrition can impact your labor and delivery, but clearly we should have known better. We should have known that preeclampsia would be a bigger subject for an entire episode. But maybe we have you come on again. I'd love to have you back and maybe dive into that as a separate subject, because I have a feeling like this, it will take us, it'll take us an hour to get through.
Absolutely. And
So
honestly, preeclampsia, I mean,
you
we're
guys
just
are cool with
barely
that.
scratching the surface with preeclampsia right now.
No, totally. I mean, that's the challenge, is it's such a complex thing. There is some new research that just was released earlier this year about providers are being encouraged. This was like a March of Dimes thing that came out, but providers are being encouraged, if they have a risk for preeclampsia, that they should be taking aspirin.
Mhm.
Where do you stand on that?
Yeah, so I always say baby aspirin is kind of the best they got, right? It's the best the conventional world has come up with to reduce the risk of preeclampsia. And when we look at the statistics, it's approximately a 13% reduction of preeclampsia when somebody starts a baby aspirin early in pregnancy. And I mean, it is a reduction, right? Is it super magical? No, right? And it comes off of the base that when we look at the research, one of the most common things that we with people with preeclampsia is this idea of issues with blood clotting, right? They have disruptions in the way they clot. And the majority of the time, it ends up becoming an excess of clotting. This is why people with preeclampsia are more likely to have things like pulmonary embolisms or a blood clot in the lungs, right? But that's not all cases, for sure.
Most cases aren't experiencing that.
Exactly. And so their idea is if we give them a baby aspirin, well, we can increase blood flow to the placenta, because what was one of the other things we talked about was this idea of hypoxia, not enough oxygen getting to the cells. And if we give them a baby aspirin, we thin the blood, well, we can get more, right? The movement is so much faster. If we have thinner blood, it's easier to push thin blood through the blood vessels than it is thick blood. So it reduces that risk of hypertension just because the body doesn't have to work as hard to push the blood flow. But statistically, we see it reducing that risk by, again, approximately 13%, right? It is a reduction. It's just not huge. Other studies have shown that if somebody takes a calcium supplement, 500 milligrams of calcium with the baby aspirin, it increases the success of prevention. Well, what does calcium do? It does a whole bunch of things. It helps with blood vessels, and their structure and their support. It plays into the blood clotting cascade. The other thing we see that nobody ever talks about is hypothyroidism, right? Hypothyroidism is something that anytime I have somebody who pops up with particularly hypertension, I test their thyroid right off the bat because I feel like hypothyroidism and thyroid disease is one of the most underdiagnosed conditions in pregnancy. And it's highly associated with gestational hypertension. Not only that, we'll see it affecting labor outcomes. We see it being associated with postpartum hemorrhaging, so many different things outside of just preeclampsia. But it is something like preeclampsia rates going up. We're seeing the rates of hypothyroidism going up in women, right? Women are most likely, or men and women are more likely to be diagnosed with a thyroid disease. I mean, the number one cause is going to be autoimmune disease. Second most common cause, iodine deficiency, which is becoming significantly more common again. And the third most common cause is either disruption with iron, whether it's too high or too low. So if you got low iron, well, then there's a whole other game when it comes to preeclampsia, as we do find that people who are iron deficient, even without anemia, they can be iron deficient and their hemoglobin and hematocrit are beautiful, have higher risks of preeclampsia. They also have higher risks of hypothyroidism. Iron plays into a number of different enzymes in the body. It goes into making your hormones. It goes into several different things, right? How we make our neurotransmitters. And so there's a whole other game, right? Again, like I said, we're just kind of scratching the surface and it's so complex.
But everything that you're saying still goes back to nutrition. And that's what
Absolutely.
we're taking into our body. Are we getting
Absolutely.
enough food that has iron in it? Are we getting enough of the,
Right.
it just keeps going back to nutrition
Right.
and, and the fact that much of what we're eating is processed,
Mm-hmm.
stuffed with hormones,
Yeah.
toxic levels of.
Right. And if you go into like the processed food game, it's also, there's this devoid of nutrition oftentimes with processed foods, high sodium, that whole game. But that's also this idea of like old fat, right? What happens when you get old fat? It becomes rancid. It's kind of toxic. Like, have you ever opened up an old rancid bag of potato chips? Right? Oh, like it's so off-putting. Right?
Yeah.
That is negatively impactful on the body, right? That's one of the things that we'll see. It's the same aspect of like hydrogenated oils. Those are horrible for you, right? We're finding that out. People nowadays know. That's why every company is like, well, we're just going to avoid those. We'll put something else in. Not everybody, but a lot of them have come on board with that. But if you just have oil that sits around and goes bad, it's just as bad for your body, right? Steals your antioxidants because your body's going to say, we got to stabilize this wonky fat over here that's starting to degrade. So there's an element of that aspect to things where, when I look at like the PUFAs or the polyunsaturated fats, everybody talks seed oils, right? And how bad seed oils are for you. What makes seed oils bad is that they're unstable and they go bad quickly. They get rancid quickly. Cultures have used seed oils for a very long time, but they used them fresh. A fresh seed oil is very different than a seed oil that's been sitting in a plastic container for 6 months to a year. Right? That's a very different seed oil. It's very different
I
than a
made it.
seed oil that's been put into a processed bagel that was then cooked and fried and heated and then put on the shelf. Very different oils.
Yeah. I mean, I made the switch in my household many, many years ago. I only cook with avocado or olive oil. When I'm cooking now, I just have completely eliminated any other vegetable oils or canola oils or anything like that. And excuse me. Sorry,
Bless
pardon
you.
me. And I've seen it make a difference in our family for sure,
Mm-hmm.
like in our diets and stuff. And I mean, I probably did that 15 plus years ago now, and it's just commonplace. I never use anything else.
Yeah.
So it's little things like that, like those are little things like that you can in fact do, right?
Yeah.
So I'm going to ask you our final question, Sarah. Things like that seems like a good place to wrap up. So we always ask all of our guests, speaking of the village, besides a functional medicine doctor, what do you think is a critical role in a pregnant family's village?
I would say having a rock, a support person, a non-judgmental support person. And I think for a lot of people, that ends up becoming like a very trusted family member. And I think sometimes as a woman, having it be a woman is a very important thing. Like husbands are always supportive, but it needs to be a non-spouse or a non-partner, somebody outside of that who can be just a person that you can bounce things off of, that's always there to support you from an emotional perspective, because pregnancy is a lot. It's a lot of change, regardless of what number pregnancy it is for you, right? Having somebody that you can just talk to about things that isn't right up in there, right? That's there. They're going to be there. For me, it was and is always my sister,
Yeah.
right?
That's awesome.
For people, it's a doula.
For a lot of people, it's a doula. Exactly. Exactly. Some people, it's a friend. Some
Right.
people, it's a mother. Some people, it's, again, it can be a doula, right? There's a lot of different options there. Sometimes it is your provider,
Yeah.
right? But you got to have somebody that you can feel like you can voice things to, who's a support person that's always going to be there. Like I said, the rock,
Yep.
right?
Yep.
Well,
Yep.
Sarah, this was so nice. I really want to have you on again, talk a lot deeper into like nutrition specifically for labor, because I think it's really important. But I learned a lot today. Hopefully, if you guys are listening, you did too. All of Sarah's information will be in the show notes. And I am super excited to re-listen honestly and like learn more of all the tidbits and have your book links and everything in the show notes as well.
Sarah, thank you so much. We appreciate you. And thank you to everyone who's listening. We appreciate you, and we'll see you next time.